I apologize again for yesterday, you sitting through a meeting for your item and not knowing that was why you were in the room. I'm very sorry.
That's
Seemed like
okay.
a very important conversation, Holly.
I really did think you were there to be part of that conversation, which I was excited to see you in the
I was
room.
glad to hear what the conversation was. You know what I mean? Like, it is helpful, kind of, especially as we're thinking about our strategic plan. Like,
Yeah.
what are y'all processing through right now? What's realistic? What's a threat? You know what I mean? Like, I think it was useful.
Yeah.
So,
Anna,
no
do you
problem.
typically attend those meetings?
I'm in and out. I'm not usually there the whole time.
Mm-hmm. Yeah, Chelsea gave us a heads up, Holly, so we knew that things were maybe going to get pushed, so it wasn't a total surprise.
So,
All
Christy, if
right.
it's okay with you, I'm going to go camera off. I'm just kind of here for awareness purposes, but
Yep.
Okay.
Totally. All right. Well, welcome everybody. Nice to see you. Hope you've had good summer. I can't believe school's starting here in a couple weeks. It's wild. We've got some new folks today, which is great. So we'll do a quick round of introductions. We're going to spend the first half of this meeting really digging into the behavior rehabilitation services barrier that Lynn Lincoln Benton submitted many, many years ago. I think it was 2021. So Jennifer, great to see you. But I know this is a concern for everybody across the state. And then for second half of the meeting, like usual, we'll just kind of have open style conversation. If there are particular barriers that people are looking for an update about, it's a great time to ask for system partners. If there's something that you feel is relevant to share with our regional partners, that's also great to hear about. So does that sound like a plan? Is there anything specific people are hoping we talk about in addition to the BRS barrier? Okay. All right. Well, I think there's a couple of people on here that I haven't met before. If I have, it's been a minute, so forgive me if I've forgotten. But I'm Christy Hudson, she, her pronouns. I'm transformation manager in support of the System of Care Advisory Council. I'll call names off. How about we'll do Karsten and then Amy.
Sure. Hi, I'm Kirsten Peterson, she, her pronouns. I am actually, I just transitioned my position within Care Oregon to Jackson Care Connect, and I'm the Child, Youth, and Family Program Manager, and I work with Tracy on systems of care work.
Oh, great. Welcome.
Nice
Thanks
to
for
meet
being
everyone.
here. So nice to meet you.
Good morning. My name is Amy Gordine. She, her pronouns. I am a policy analyst for the Medicaid fee-for-service behavioral health team.
All right, Holly and then Anna.
Hi, I'm Holly Heiberg, she, her pronouns, and I'm the Medicaid Policy Director.
I'm Anna Williams, she, her pronouns, Executive Director, System of Care Advisory Council.
All right, Corinna and Danny.
Good morning, Corinna Hazard, she, her pronouns, SOCAG staff. Excited to be here.
Morning, Danny McAllister, System of Care Coordinator for the Central Oregon region, and I am with Pacific Source.
And Kristen Anjane.
Chris Barnes, I am the Children and Family Systems Director for GOBI and EOCCO, covering 12 counties in Eastern Oregon, and I use she, her pronouns.
Good morning, Anjane Bolin, ODHS Child Welfare Assistant Program Manager in Treatment Services.
Desiree and Tracy.
Hi, Desiree Stang. I work for Samaritan Health Plans. I'm the Behavioral Health Program Manager, and I apologize, my camera's not on. I'm driving to an appointment.
Great, thanks for being here.
Hi, Tracy Howard, she, her pronouns. I'm System of Care and Behavioral Health Specialist at Jackson Care Connect in Jackson County.
All right, Corinne, and then special guest Sonia.
Hi all, I'm Corinne Hale. My pronouns are she, her, and I work with Columbia Pacific Coordinated Care Organization as the Children, Youth, and Families Behavioral Health Manager.
Good morning. My name is Sonia Littledeer Evans, she, her, pronouns, and I am the Deputy Director for Deschutes County Juvenile Community Justice and a SOCAC member.
Thanks for being here. Selby and Jennifer.
I'm Selby Stebbins. I use she, her pronouns. I'm the System of Care Specialist for Washington, Clackamas, and Multnomah County, and I'm based at Health Share of Oregon in Portland.
Good morning. I'm Jennifer Schwartz, she, her pronouns, and I am the System of Care Manager in Lynn, Benton, and Lincoln counties for IHN.
All right, Napua and then Jesse.
Hi, Napua Rich, Senior Policy Analyst on the Children. I'm new to the team, so I don't remember the full name, but for EPSDT.
Oh, great. Thanks for being here.
Hi, Jessie Egan. I use she, her pronouns, and I'm the manager for the Child and Family Behavioral Health team in the Behavioral Health Division at OHA.
All right, and Alex Palm is here. I didn't think you were going to be here, Alex. Good to see you.
Surprise. Hi, everyone. Alex Palm, he, him pronouns, Child Welfare Central Office. Good to see you all.
All right. All right, let's get into it. So behavior rehabilitation services, this was a barrier that came to us from Lynn, Lincoln, Benton many years ago. I think it was 2021, Jennifer, if I'm not mistaken. And there were 5 recommendations that you all provided. We've got Amy Gordine here today. I also invited Anjane to speak a little bit about BRS from the child welfare perspective. And then there had been some recent kind of curiosities and questions about accessing BRS via juvenile justice. So Sonia, if you're able to kind of speak to that at some point as well, that would be great. I didn't have any like specific agenda, so hopefully you all can kind of bounce off of each other a little bit. And if folks have other questions, or other suggestions, recommendations that aren't specifically being talked about or haven't been proposed in the barrier, like let's also talk about those things. I know there's a lot of work and dreams of improving the BRS system. I know that OHA had requested additional funding from the legislature. That did not happen. So we're kind of in a holding pattern and just curious about what other solutions, what other things could we be doing in the meantime while we wait for additional resources to come our way. So just to remind you all, I'll just flash these 5 recommendations that originally were proposed. And Jennifer, these things might be, some of these things might be already addressed, right? Some of these things might not be relevant any longer, but just to kind of take us back a little bit into time, these were the 5 things that you all requested. 1 was to fund BRS treatment foster care in our region. I think there's a little bit of confusion in here that hopefully we'll address today. The second was to expand access to all youth. Right, BRS is a Medicaid state plan service. It should not be limited to child welfare. Work is underway to do that. 3, edit the names of different terms of care to avoid confusion. For example, BRS Proctor Foster Care and DHS Child Welfare BRS are 2 different types of services, yet they have similar names. I am still very confused by BRS. I've only been around for 3 years, and this is like, it is still baffling to me. It seems very, very complicated and confusing, and I wonder if that may be part of what we could work on, is trying to make this a little bit simpler for community at large to understand. 4, continue eligibility based on youth behavioral needs rather than their mental health or SED needs. And then 5, establish the ability for local control and co-management of service between District 4 and IHN CCO. I think there was some work that happened here initially right after this barrier was submitted. DHS Child Welfare did submit a barrier, or kind of a response to the region. That was many years, that was 4 years ago now, and I don't know if anything else has specifically happened within District 4. But that's a little bit of where this story began. So hopefully that helps address, or, kind of sets the stage a little bit. Who would like to begin? I don't know. Amy, do you want to get us started, and then we can move to our child welfare and juvenile justice partners? What makes sense?
That'd be great. I mean, I did a presentation for you based on also the discussion you had in June, to have kind of an overview of BRS from a Medicaid perspective. So I could do that presentation, and then it's pretty short. And then at the end, we can open up for questions about pieces that may be really specific to child welfare or Oregon Youth Authority.
That sounds great.
Okay, great. Let's see. All right, is the slideshow showing up?
Looks great.
Excellent. Well, as mentioned, my name is Amy Gordine, and I'm Medicaid Policy Analyst on the fee-for-service side of the work. I did just, I will send this presentation out to everyone, and I always think we use so many acronyms, and so wanted to provide a list of acronyms you may see in this presentation or that might be said verbally, just so you know. I'm sure you're familiar with a lot of them, like BRS, which we're talking about today, but there's some others, Child Caring Agency. I noticed on one of the recommendations, there was the use of JD. I'm assuming that means Juvenile Department, but if that is incorrect, if SOCAC could let me know what that JD stood for, that'd be great. LPHA is Licensed Practitioner of Healing Arts. These are all our different agencies and the Oregon Health Plan. Provider Enrollment Unit is OHA's unit that enrolls Medicaid providers for fee-for-service. POP is Policy Option Package, which, as Christy mentioned, was not approved for BRS. SPA, or it means State Plan Amendment. It's our agreement between our single state agency in Oregon for Medicaid and the federal government regarding our services through Medicaid. And then TFC can refer to treatment or therapeutic foster care. So hopefully that's just a little helpful setting of the stage. Also, from a Medicaid perspective, BRS is a Medicaid funded program that is described in our state plan, and it is intended to support the skill building and offer behavioral interventions in a safe environment for children who, due to their behaviors, cannot remain in an in-home setting. They have to be licensed as a child caring agency, and their services have to be medically necessary and medically appropriate as defined in our EPSDT rules and our Medicaid BRS rules. It's not intended to replace behavioral health services provided by a licensed or certified individual. And it's also not an institution for mental diseases, a psychiatric residential treatment facility. It is not treatment or therapeutic foster care, and it is not an alternative to foster care placement. It is.
Amy, Jennifer's got a question here I think will help. How does BRS differ from treatment foster care?
I think if we could get through the presentation and then tackle those things, some of these things will be answered, and some of them I'm going to need DHS and maybe OYA to answer. Is that okay?
Sounds great. Yeah.
Thanks. So we have had some updates. A lot of the work that we're doing is very intensive behind the scenes to update all of our BRS prior authorization and provider billing processes through OHA's Medicaid Management Information System to align it with the same practices as other Medicaid providers. We've been working on other parts of the prior authorization process, including using Comagine Health as our designated licensed practitioner of healing arts that does determinations of medical necessity and medical appropriateness. They are also helping us look into the types of care and that we all have questions about for BRS. As mentioned, we were unable to obtain the funding through the POP, but will continue to seek resources through all means available, including potentially another POP for the next biennium. Our rule writing continues internally. There's lots of updates that need to be made, hopefully to simplify a lot of the confusion around BRS. And there will definitely be community outreach opportunities, and those are always posted on our BRS website. There's links to it in this presentation. And so we'll be able to communicate that way. We'll also definitely reach out to Christy so she can share that with all of you. Tentative timeline, I believe, is around the end of this year, beginning of next year. Oh, sorry. So I did list out some of the recommendations. The first three I feel pretty confident in answering. So treatment foster care is not a covered Medicaid program. It was funded and contracted for separately from the Medicaid BRS program. So treatment foster care is not in our state plan. OHA was not funded to provide treatment foster care. My understanding is that was funding that was allotted to child welfare to develop that program. The second one was to expand access from justice service and foster care to JDs. Is that correct? Is JD Juvenile Department?
Yes.
And OHP members for behavioral health treatment foster care. Again, treatment foster care is not a Medicaid covered service in Oregon and therefore can't be offered to OHP members. BRS is a service in our state plan covered by OHP and should not be limited to child welfare as mentioned. And it is currently available through OHP to children in the care or custody of child welfare, also the Oregon Youth Authority, and through county contracted providers that contract with OHA and participate in a cost sharing program. And I'll go over that in more detail next. So it is available through all of those avenues currently. And as Christy mentioned, our goal is to continue to advocate for it to be even more accessible, but that will be dependent on funding. And the third concern was about editing the names of different terms or types of care in BRS to avoid confusion. So we are working really collaboratively with DHS and OYA to simplify and streamline the use of the language related to BRS as a whole, in addition to the types of care. And so I did provide a slide that talks about the different types of care. So you can see what they are. Ooh, except for my typo, I'll fix that before I send it out. Currently, we've contracted with Myers and Stauffer as well as Optimus to review the current requirements in rule and rates for each different type of care you see here. And so we can identify potential areas where we can simplify or streamline the types of care offered through BRS and and create some clear definitions and criteria about which each one is, and identify and ensure they're all being used. And if any of them are not being used, if there's any consolidation we can do for types of care. So they're offered in two different models. We have the Proctor Care model, and this is our definition that you can find in rule. It means the services and placement related activities that are provided to a client who works or who resides in an approved Proctor Foster parent home. And then the other model is a residential care model, where it's a residential community setting and not in a Proctor Foster home. The different types for Proctor is shelter, assessment and evaluation, community step down, independent living, Proctor Care, and Proctor Enhanced Services. And then on the residential side, you will see many of the same, including basic residential, and this is supposed to say intensive residential, short-term stabilization, and intensive behavioral support. So where you can kind of find a little bit more information, although again, we're still working on better defining each type of care, you can find more information. Our main rules for BRS for Medicaid are found in Oregon Administrative Rule Chapter 410, Division 170. This is LINK. And then here in the section 0030, you can find staffing ratios for each different type of care, including the different ratios that are based on households for Proctor Foster Care. And then in the section 0090, it describes the number of service hours for each different type of BRS care that is required to be provided on a weekly basis to a child in each either residential or Proctor setting. So that gives you some of the information we do have in rule. You can find it there. And then we also have our website. This links to it, and there you can find there a comprehensive BRS rate table, and it lists the rates associated with each type of care. And then we also have a guide for our rules, and in Appendix C, which is PDF page 47, if you want to skip ahead, it summarizes the information from rule and contract based on the type of care name. And then our website also includes continuous updates with resources and announcements that may help with understanding and keeping up to date around the different things we're working on. Then these are the following providers that are contracted with Oregon Health Authority. So we have Clackamas County offers shelter care. Jackson County is contracted to offer basic and intensive rehabilitation / residential services. Mostly they provide intensive. One step we have already decided to take is there isn't really a difference between rehabilitation and residential type of care, so we are going to remove just the rehabilitation. So it removes one name off of our list. So both basic and intensive settings will be called residential, and we'll get rid of the rehabilitation in our rules. Josephine County offers a basic rehabilitation. Marion County offers a shelter, Multnomah County offers shelter, and Washington County also offers basic rehabilitation. And so all of those counties participate through a cost sharing program where the county BRS contractor is responsible for paying the non-federal share or the state share portion of any claims submitted to Medicaid for reimbursement. So they have when they enroll as a Medicaid provider, they fill out a form that agrees to that cost sharing program, and it sets up a leveraged account where when they go to bill, they submit the state share portion of the service rate for BRS into an account, and then they bill their claim, and OHA is able to pull down the federal match for them And then the claim is then paid in full back to them. And yes, Multnomah County's A&E program closed this year, but they have maintained their shelter contract with OHA. So this would be, I noticed from June, there was questions about what the process was for becoming a BRS provider with OHA. We are exploring options to simplify the current process, but until then, any provider interested would be required to participate in the cost sharing agreement I just explained, including the state share of the service rate and costs related to placement-related activities. If a government agency such as a county juvenile justice program is interested, they can reach out to OHA by emailing our Medicaid programs email box and express their interest. OHA will schedule a meeting with a potential provider to discuss all the requirements of being a BRS provider, what type of BRS care they're interested in providing, and also go over that cost sharing aspect of the agreement. And then if it is a residential setting, a tour may take place as well. If they decide they'd like to move forward, the potential provider would be required to pursue a license as a child caring agency. They would be required to enroll as a Medicaid provider type 06, specific to BRS counties, which will identify them as part of the cost sharing program. And then they will also have to enroll any staff that are program coordinators or social service staff as a non-payable provider or rendering provider, it's often referred to. And then OHA will initiate a contract request through our Office of Contracts and Procurement. We'll go through all those steps, and once the contract is executed, there will be a contract kickoff meeting and training, and then the provider can begin accepting referrals. So hopefully that covered the first three barriers. I'm not really 100% sure, or sorry, the first three recommendations. I'm not really sure what the last two recommendations are about regarding continued eligibility based on their needs rather than based on behavioral needs rather than their mental health or substance abuse needs. Since BRS is not a mental health or substance use disorder service, the eligibility is based specifically on BRS criteria and rule, and that BRS remains medically necessary and medically appropriate for that child, which happens through our prior authorization process, which includes the recommendation by the licensed practitioner of healing arts. So if there was something more to, if there was something about continued eligibility that I missed there, if someone could explain that recommendation to me better, I can offer hopefully a better answer either now or later in writing.
Jennifer, do you want to add anything else here?
Yeah, I can try to speak to this. So again, this is really confusing, and I think overall in our region we didn't have the Medicaid BRS program or the BRS treatment foster care program at the time that we submitted this barrier. So anyway, so that was the first recommendation. But in terms of this recommendation, I guess we're talking, and the rest of the recommendations are really around the Medicaid BRS program. And in this case, ensuring that that eligibility wasn't limited to mental health or substance use disorder. And even today with the BRS program and the information that's collected to determine eligibility, I mean, it does sound like families have to submit psych evals and their a mental health diagnosis. And I'm not sure if that's part of determining their mental health evals is if that's also used to determine eligibility. And I guess with that one, it was just let's not limit eligibility. Let's keep it as broad as possible. And you know, and I think it is because I think what you said, it was based on medical necessity, which that would fall under. But
Yes.
But I guess, yeah.
So for Medicaid purposes, a diagnosis is required. It can include sometimes a Z code, codes that are more diagnostic in nature and not necessarily a traditional mental health or substance use disorder diagnosis. So it could have to do with social determinants of health, you know, for BRS, as long as it's related to the medical necessity and medical appropriateness. We are looking into more information to also simplify that. And then while some referrals for a prior authorization do include a psych eval, it's not required, but if the child has one on hand, it can be submitted to help show the current state and potential need for BRS services, because although they are not behavioral health services, they are meant to support the behavioral needs of the child and ensure that they are connected to any mental health or substance use disorder treatment that's identified for them.
Amy, I'm also looking at this other question that Jennifer posed earlier. What are the eligibility requirements for BRS, and what supporting documents are required to confirm eligibility? It sounds like to me, due to EPSDT, that as long as a practitioner deems that BRS is medically necessary and medically appropriate, that would be sufficient?
That is not the only criteria. They have to be eligible for OHP.
Okay.
They have to be a child under 21, and they have to also not be in a current DD or behavioral health residential setting that there's no discharge plan for. So if they're already receiving residential services in another setting with no plan for discharge, then it would be inappropriate to authorize BRS services. But if there is a discharge plan and BRS is part of that discharge plan, then we can go through and review those. So those are the eligibility criteria. I can follow up in more details. We have a lot of resources about all of that on our website, but I can answer that one in writing separately so you can have connection and all the rule language included.
Okay, because what I'm also not hearing is where child welfare and juvenile justice involvement comes into play in terms of the eligibility.
It is not part of the eligibility criteria. It is how the program is administered and funded. So DHS and OIA send their prior authorization request to OHA as well for processing.
Yeah, you may have just answered this. So for the Medicaid BRS, has access been expanded to OHP members as well as youth in the juvenile justice system?
It is currently available. Currently available for kids in child welfare and OIA custody, and also per the 6 counties that OHA contracts with.
So in those 6 counties, does that mean a kid not child welfare, juvenile, and justice involved could access BRS?
It does, because it is a cost sharing program. They manage their own referrals. So often, since it is county based, they don't do the prior authorization, but they are paying for those youth. So often the referrals that come to them are youth in their county and are often justice involved, but not in OIA custody.
Okay. But they wouldn't have to be involved in either of those systems to access it if the county said we'll pay for it.
Correct.
Ah.
I'm not aware of any of those programs taking youth outside of the juvenile departments.
Amy, I was going to ask that, what's practically the application of that? Does that occur?
Practically, the referrals come from their juvenile justice system, but what is possible is broader than that.
I would love to recognize that with an underfunded BRS system, it's not funded yet to really, it may be in exceptions in certain cases, but until we can really grow that, provide the technical assistance, create the pathways, we're gonna, I don't want people to walk away thinking that we can grow this like this in the counties that we have it. I want to be realistic about that and the work that really needs to happen across BRS in order to make that reasonable for people to be able to access those services.
I just want to add, that is the goal, right? That's the collective goal, that any OHP eligible member that can meet medical necessity and appropriateness is able to access BRS, whether or not they're involved with child welfare, Oregon Youth Authority, and juvenile justice. And so that is like the ultimate goal. So we don't have, really 3 primary doors of access, and that really, this is a Medicaid service. As you're describing, Holly, we're not there yet, but that is something that is within target that we keep moving toward.
Sonia?
Yeah, and I would just add to kind of tail on both of those last statements is most of the programs that are running by a county juvenile department or have an OA contract in a county juvenile department space, they are very institutional. Most of them are prior detention facilities that have been converted to meet BRS standards. And so, I'm hoping that's not the long term, is to put non-justice involved youth in those settings, because they are very built for a correctional type setting. And if I wish even the juvenile justice ones weren't, if they were more in like a therapeutic setting, but those settings, and then also mixing populations. There's a lot of research that says that can cause a lot of harm. So
interesting. Okay, thank you. That's super helpful. Can we circle back a little bit and I'm curious, thank you, Amy, for that kind of like the Medicaid grounding. That was really helpful.
I'm hoping we can talk about number 5 unless that one's resolved. I just want to make sure we check all the boxes of what I was asked to talk about today, and then absolutely circle back to more questions. But I don't really understand what 5 is. I don't know what how I can assist or answer that.
Jennifer, is this still a challenge?
No, I think this was a kind of a wish of Bill Bushka. So and he's no longer with IHN, so he can't speak to this one. But
the aim here was that youth in Lynn, Lincoln, Benton could access BRS directly without having to go through like an OHA prior authorization channel. Was that the dream here?
That's what I imagined. Yeah.
But I also
If
don't
I
think
remember
sorry,
right, okay. I think this was, and I'm not in Bill's head either, but I think the case he was trying to make is that IHN as the CCO wanted to be able to pay for the BRS services. And we weren't able to find a way to do that.
But you did work with him on trying to figure that if there was a mechanism, Alex, that we would be able to, and I'm assuming we got called in because it was a DHS District 4 thing and you're the creative funding whiz on the DHS side, for better or worse. Is that accurate? You like tried to help figure out if IHN had a mechanism.
Yeah, I think
and
we
you
just
couldn't
tried
find
to
one?
see if it was something we could do at that time but I don't think there was a mechanism for it.
Okay, thanks. Appreciate that.
If anybody has questions about that, I don't wanna waste the time here, but happy to have a side conversation about why that's tough to do.
You mean why CCOs can't pay for BRS directly? Okay. But Jennifer, I don't think that any of your counties were listed as current providers, correct? So that could be that could be something your counties could reach out to OHA and be like, hey, we want to, as a county, we want to provide BRS. And there's nothing preventing them from doing that today.
Yeah.
I'm looking at Holly and Amy, and they're both, their faces and their heads are saying, yes, that is a possibility that IHN could pursue.
I want to say out loud, because I've been sitting in some other rooms with our CCO and county reps, and I think that there's lots of things we can do across our system to improve. But our team at Medicaid really, there has been a shift in the last couple of years. And when we say, yeah, like you can pick up the phone and call us. And I think that's often where we have issues. Maybe people don't think they can really do that. And I just want to say that out loud. You know, if you want to pursue that and think about it, we will be a thought partner to figure it out.
Thanks,
and
Holly.
Medicaid, I will just add a layer of that Medicaid is obscenely complicated. And Oregon's Medicaid is one of the more complicated versions of Medicaid. And so being able to talk to somebody in the division who is in problem solving mode, rather than just in sort of compliance mode, has really sort of changed for me, my ability to think about creatively, like if we wanted to do this, is it possible and what would it take? It may be that it's a 3-step process that needs federal approval, whatever it is, it might be very complicated, but it's often doable if you can figure out how to frame it in a way that fits those different mechanisms, right? So you need to really partner with your Medicaid folks and try to be creative and out of the box about how could we get this done. And I've seen a real shift in the Medicaid team about being more problem solving and less liability limitation focused in the past few years.
Okay, so now that we have like the and I know there's still some unanswered questions in the chat, but I'm still trying to get my head around this, so bear with me. So we've got like the Medicaid, we understand how it's paid for. What I'm still not understanding is how child welfare and juvenile justice play in the sandbox, given, for better for worse, that's really only the kids who are accessing this program right now. So I guess, Anjane, do you want to talk a little bit about where child welfare fits into this and also help once and for all explain how treatment foster care is not BRS?
Once and for all. Well, Amy touched on a lot, and I know there's a lot of questions as well. And I think what also complicates all of the language confusion and just the complexity of everything is there's an evolution of BRS, of terms, of contracts. And so maybe what folks were used to 10 years ago is not relevant today. And so just being able to keep up as well is, part of the issue. Really quickly touching on this idea of TFC or therapeutic foster care, that actually used to be a level in BRS. And so folks who remember BRS therapeutic foster care, we used to have contracts, but that terminology went away and we decided to use Proctor care instead to eliminate the confusion of BRS being mental health. And so that is why that shift was made. And some folks, I think, still remember it as TFC. And then also, still to this day, I think there's just interchangeably BRS, TFC has been used as meaning kind of the same thing, just people trying to wrap their heads around what BRS actually is, because a significant number of the young people that at least access BRS through child welfare also have significant mental health needs and are accessing services. So, caseworkers, teams think BRS and mental health are often one and the same. So it's a lot of trying to provide information and understanding and breaking it down. But okay, so BRS versus like treatment foster care. So back in 2019, the legislature gave child welfare funding to create treatment foster care, or expand what that actually looks like. Why it was given to child welfare, maybe Palm, you can provide some more context around that. Seemed a little bit out of place for us to have received the funding and then to establish that. But we were tasked with creating treatment foster care. And so what we have done over a 5-year demonstration project is look at what are the needs of the young people accessing BRS. So we have the need for behavior supports and services, and often the mental health integration piece as well. And so we created behavioral health treatment foster care, or BHTFC. Another acronym, another term, but I just want to make it clear it's BHTFC, Behavioral Health Treatment Foster Care. So this is something that is a combination of BRS plus mental health services. And that is to be able to provide an integrated service package for a young person who is in a BRS placement, a BRS Proctor placement, so a certified family home. They're in one of these certified Proctor agency programs, and they are also accessing mental health services. And so that is the goal for young people with more acute mental health needs, is to be able to access this level of care. And so currently, as Amy was explaining, this is not a fully Medicaid funded BRS program. We've been combining BRS with general funds to be able to support this level of care. OYA is also using this level of care as well. And we have been working with OHA at the table throughout this 5-year demonstration project. So we're all on the same page as to what we're learning, what this looks like, what is working, what's not, with the hope down the road that one day this would be a full Medicaid service and not just a child welfare specific BHTFC or OYA specific BHTFC funded type of program. And then Jennifer, I see your question about can parents access TFC or BRS via FSS. So a family support services case. So through a voluntary case in child welfare, if a voluntary case is opened, which is a whole assessment process that we go through to determine if that's appropriate. And then based on that, if there's a determination that yes, it's appropriate, the need is there. We have quite a few young people that access BRS through our child welfare contracted programs through voluntary placements. That is not ideal. We don't want to have families and young people coming to child welfare just to be able to access BRS. But that is certainly a situation where we have accessed beds for those families and young people. Okay, that was a really broad overview for just BHTFC specifically. Any questions about that before I move on just to a few other things?
Yeah, so Anjane, that whole BHTFC thing, that is, it sounds like not financially connected or authorized by OHA and the program Amy.
It actually is, because we're combining placement in a BRS program. So that young person still has to go through all of that eligibility process and requirements that Amy described. So the first layer is to get that BRS authorization, but then also internally we're looking at, does this young person have elevated mental health needs? Do they meet the criteria to be able to go into a BHTFC service bed?
Got it. Okay. So just as like a real example, youth placed in a resource home has more complex needs. You would do the prior auth through OHA for the BRS placement, and that might be all that kid needs, just the OHA BRS. Or you might say, no, the kid needs the child welfare version of BRS with the behavioral health. Oh my gosh.
And I wouldn't say the child welfare version of BRS, because BRS is BRS, right? And so we might say this kid has elevated mental health needs. They would best be served by intensive outpatient mental health services. They've been in and out of the ER. They've tried standard outpatient. Based on their history of placement disruptions, their access to mental health services over the past 6 months to a year, we think they would be best served in a BHTFC bed where we have BRS plus the mental health supports. So BHTFC right now is specific to child welfare and OIA. So both agencies have contracts for those services specifically.
But not county juvenile.
Correct.
Okay.
And our child welfare contracts, which are administered out of treatment services, those are all statewide. And so I know that part of the recommendation was to have more localized regional homes and funding for BRS. So we used to have many years ago contracts that were specific to regions, and we really had to readjust because of the financial stability of programs, the lack of access of the number of beds in specific regions. Programs needed to be able to serve more kids and not just, maybe the few that were in the local area. So all of our contracts are now statewide, though we can absolutely try and prioritize specific regions so that we can keep kids in the local community. That is our absolute priority. And so that is why we fund Foster Plus, which I think in some of the recommendation follow-up that's discussed with the funding for Foster Plus, which is the collaboration of all of the proctor agencies that child welfare contracts with, for them to be able to support each other and network, use resources to maximize recruitment and retention across the state, and really look at where the need is and develop capacity where able. And so that funding and that work is still happening. We are absolutely trying to expand proctor care throughout the state, so BRS proctor care throughout the state. We do have currently a solicitation open for agencies that want to provide BHTFC. So if there are new agencies that are interested in that level of care, we have that solicitation open, and we are looking at expanding residential beds as well, because those are limited to certain areas throughout the state. So expansion and looking at geographical area is absolutely important. And we track it on our dashboard too. So we have a data dashboard where we see how many kids have to go out of their home region to access BRS, because we want to be aware of that as we identify capacity building, where expansion needs to happen, where we're resource heavy, where we need to really focus on building and developing. So that is something that we look at as well. I will have to pull for you, Christy. We have one internal treatment services dashboard and then one that is for child welfare. I don't think we have a public facing version one of that quite yet though.
Okay, Jennifer, is BRS proctor care different from BRS, or are they the same?
BRS proctor care is a type of BRS setting. So it can either happen in a proctor care setting or it can happen in a residential setting. And then there's different types of proctor care services that can be offered. And that's all listed in the slideshow with resources that I'll send out.
And then just to clarify for myself, the BRS not the BHTFC, which systems are they specific to? Like who can access BRS?
Individuals in the care and custody of, let's see, I've worded it so nicely somewhere else, in child welfare, an OIA custody, and through the 6 county contracts that OHA has with county juvenile departments.
And just to say the goal out loud again, we want all eligible kiddos in OHP to be able to access these services. That's the road we're on.
So, and maybe I missed this because I had to kind of step out and redirect my attention a couple of times, but we did ask the legislature for funding, which was basically what we were calling BRS for All, which would have opened up this opportunity, right, where all eligible kids who are on OHP could have had access to BRS if the funding had been provided, and some other work would have needed to be done, right, to like build up that program. It wouldn't have just been like, oh, we got the money, poof, problem solved. But that money did not come from the legislature. And so, like, there's sort of 2 pieces that I understand. There's one, this is currently the only, and Pom sort of alluded to it earlier, there's some complexities in terms of how the money moves from place to place. Right now, it really can only go through these contracts to child welfare contracted or juvenile justice directed, right? Whether they're county juvenile or OIA, but they're juvenile justice directed money. Or it's Medicaid money, but it has to go through these little pathways, right? It can't just go out from OHA. I don't totally understand why that is, but I know that it is a thing. And so getting the money to OHA so that we can have those contracts would have then also needed to figure out how to open up. And I'm looking at Holly, is that accurate? That you would have had then, even if you got the money, you'd have to figure out how to like make a new little portal for it to go out so that OHA could contract directly for those services rather than having to go through child welfare or juvenile justice?
They would just bill through MMIS.
Yeah. So providers, and we've been doing a big shift with our OA and ODHS partners. There's been a lot of work behind the scenes. So the Medicaid providers go into our MMIS system, and then they can bill directly through that system. And so there's been such good work with the system we have right now for BRS to sort of update and get that standardized. When we get ready to expand out, that will make it more clear, hopefully, as we engage providers who have already been doing these services. I know everybody's like, what the heck? That Medicaid is so complicated. And I just want to acknowledge that straight up. It is. And we're working really hard to make this more consistent under the hood. And there are plenty of ways to move towards our expansion. I do want to call out that it will take conversations with our team. So, Napua is new to this position, but not new to Medicaid. And she will be a really important leader as we begin to build out this expansion. And Amy has been in it, even though you would never find BRS in her job description. But we said, this is really important and you need to do this. And so she's taken it on for the last couple of years. So this took me a year to understand what was really happening. And I still have questions even when we had this briefing. So it is complicated and it will remain complicated. CMS is complicated. But I just want to say, as we try to move towards expansion, and I know a lot of you in this room will be important to see how that looks in certain counties and how we can design it meaningfully. And I just want to say, please reach out to Amy and Napua. We will take the time. We will sit down with people to really design how this can work. And as much as possible, we'll have that part that has to be done behind the scenes more in our shop and really lean on people operating in their community and their expertise in how we can best connect these services to people.
Thanks, Holly. I know we are at 10:30 and a little over time, but this has been, I think, helpful for me at least. I'm still curious if our juvenile justice partners have anything to add into this mix. Sandra, I don't know if Sonia's still with us. Do you have anything else to add as it relates to accessing BRS via OYA or county
I'm
juvenile?
here, and Monica Moran is here with me too, who is the manager of our community resource unit. They're the team that manage all of our contracts, our BRS and non-BRS contracts with our residential programs in the community. I don't have a ton to add, except for no, our programs are, you have to come through our doors to get into our programs. And we would love to see the ability for other folks to be able to access this level of care without having to be committed to our custody. We would be happy to support OHA or anyone else in, somehow we got here where we have, a number of residential programs, and we continue to expand. We are ongoing building new programs and or building contracts with folks that want to do this work. And so we have a model and a process, and Monica can speak to that very clearly. And yes, we're rolling with a bunch of changes and stuff right now that is changing a bit of our model and our process. But we very much would love to see these resources being accessible to other folks, because we do find that some kids are committed to our custody solely because, I mean, they will have criminal involvement, juvenile justice involvement, but would not need to be necessarily committed to our custody and made that much closer to go to correctional facility if they had access to those programs. So
yeah, so that makes me curious what's happening at the county level, because if I'm understanding it, it's only those 5 or 6 counties that operate BRS via the OHA contract. Like, what happens in the other counties? Are those kids able to access BRS?
A few of those counties that have their own BRS program, they do take referrals from other county juvenile departments. I don't know that all of them do, but I definitely know like Jackson and Josephine, So yeah, I mean, that can happen, and it does in some instances. But I would say a lot of times what Sandra's talking about happens, especially from the more rural counties where there's a need for services and they're nowhere to be found locally. Those kids will end up getting committed to OYA, even though they are not appropriate for OYA, just to access the services.
Right. So
And
what's
that's
the
not just for
barrier?
BRS, that's true for, I think, what's on here next is sex offender treatment.
So
well,
what's
and
the
I will
barrier?
also add that I'm not even, and I won't speak for counties, but some kids are referred to local county juvenile justice that maybe wouldn't have to be referred or worked with at a higher level if they were able to access the services outside of juvenile justice. I mean, having worked at county, and Sonia certainly knows this as well, I remember having counseled families that like a police report needs to get generated, law enforcement needs to get it. Families would call us asking for help, and we would say law enforcement needs to get involved or we can't really help you. And that is not ideal. I mean, because a lot of those cases really could get services in another way. But that's our only kind of path.
And I think the same happens on the child welfare side as well. For young kids, that end up in our system, a lot of times, that they're pulled in just to, we know there's access to services for there. So it happens on both. So the moral of the story is we shouldn't have to commit kids to the care of the state in order to get services they need locally, which the one recommendation that was talking about local control and access knowing the other juvenile directors from the other counties, that's a huge thing. Like if we could access the services in their community while they stay at home, they would not need to go into state custody on either side.
I don't know if any of you, maybe Anjane's in the voluntary custody sort of work group as well, that we're basically having the same conversation on the DHS side, sort of more broadly than around BRS, but just around families either being counseled to or being required to voluntarily relinquish custody to DHS in order to get their kids access to services and supports that the family knows they need, but there's no eligibility criteria outside of child welfare involvement or juvenile legal involvement. And so DHS is looking at all of those cases and trends and themes within them and working with a SOCAC and some parent advocates who have been counseled to relinquish their custody of their own children to the state in order to get care, which a lot of those kids came out of adoption, came to those families via adoption, and it feels really crappy to be relinquished back to the state after you finally found your family. So like this is an issue more writ large that Sonia just sort of brought up, and we're maybe chunking it into pieces inappropriately, I don't know. But lack of community access is like the problem we're trying to solve in both of those cases.
Christy, I just saw your comment. I've answered a couple of questions too in chat. Christy, do the things in chat get captured in your notes when you send them? Great.
Yeah, Corinna. And we are also recording this, which
great.
This has been so valuable. I think we should probably just share it unless anyone's opposed to that.
Yeah, and I think I don't think your comment is controversial. I think it is the goal. It is our goal. And like we've, unfortunately, our POPs for the last 2 bienniums that would have funded OHA to have those funds necessary to do what you're asking, OHA was not funded. So it is really disappointing. We worked really hard to get it done.
But in the absence of resources, I mean, how many kids are accessing BRS a year? It's not that many, right? It's decreased dramatically over time. So if we're saying, we're serving 200 kids today in BRS, could we say, okay, we'll keep 100 of those beds for kids involved, but we're going to set aside 100 beds for kids who aren't involved? You know what I'm saying?
The problem, I understand where your brain is going, Christy, and I love the problem solving, but it also matters where and how dollars have been allocated in different agency budgets. And to be honest, I don't want to get into a position of robbing Peter to pay Paul.
Yeah, I know.
Already the kids who end up in our juvenile justice system and our foster care system have been often on the wrong end of resources. And so we need to fund the system fully. We haven't really said it out loud because I want to be careful with this, but I think we're at this point in the conversation. We're getting as scrappy as we can with the funds that we do have at OHA. I think you can already tell we've repurposed positions to try to work hard on the current BRS system. We are trying to do some minor expansion into this space where we can, but I don't want anyone to think it's not going to be the full services we would all want and expect for kids who are eligible across the state. And we don't have the people to build this out meaningfully and sustainably and work with partners to set them up for success. So we're going to try to eke out what we can. It is a priority in the Medicaid division at OHA, but we really can't do this as it is envisioned until the legislature really says they're behind it and they give us the resources to do it successfully.
Thanks, Holly. All right, Jesse, maybe last comment and then
Yeah.
we'll wrap it up.
I was just gonna say along those lines, I think, mentioning the POPs, Anjane mentioned, if funds were given to ODHS to do the behavioral health treatment foster care, and what that does is make it a DHS run program, which makes it available for youth and child welfare. When the legislature does that, that is the result. And I think the legislature maybe needs to know that giving funds to ODHS is incentivizing parents to give their children into DHS custody. I don't know that they necessarily recognize that is what they're doing. I think they're thinking these are general funds. DHS can get general funds out. It's a skill. DHS can do this well. It's wonderful. OIA can do this well, and OHA has to go through processes where we have to worry about things like medical necessity and RFP and things that we have to do, and DHS does that as well. But I think that there's sort of a perception that if we get funds to ODHS, things will go more smoothly, and not realizing that there are repercussions of that. And so I think maybe if everybody in this room knows that and can kind of help get that message out, that there is a secondary sort of repercussion of that, which is parents will continue to get the message that they have to give their children, even voluntarily, into child welfare custody. And so when we put forward a POP and say we would like to fund the entire system, that is the goal is to be able to avoid that as an outcome. So that's what we're trying to do when we say we want to do BRS for all, or we want to fund foster or respite care, or the things that we've been trying to do, and they, like Amy said, they have not been funded. So if you could all help us bring that message forward, we would really love it. That's my message.
All right. Jennifer, do you have any outstanding questions or confusions?
No, I need to think about it.
Okay.
Let's just say that.
Okay.
But I appreciate the information. It does. Yeah. It clarifies quite a bit. So thank you.
And it does seem like there are some things that are happening, like there's some rule revisions. Amy, please keep us informed. I know we've heard that these rule revisions are coming. SOCAC is really ready to help spread the word about opportunities for our partners and families to be involved in those conversations. So I don't know if we have dates and time set, but we are really eager to help get the right people to those groups. And as you work on maybe reducing confusion in the kind of terminology, would love to provide input on that. And it sounds like, there are some counties that could do something today if they had the funding for it. So hopefully those feel like some possible steps to explore in your regions. Thank you so much, Amy and Anjane and Sandra and Sonia, for being here. It was really helpful.
Thank you.
All right, we've got just 15 minutes to kind of round robin any other barrier updates. So unless there are specific items that people want to talk about, I might just call out a few things that I have heard about. Okay, Jesse, do you want to share anything about the barrier around problematic sexual behavior related to the 4086 recommendations, or anything related to minor consent?
Sure. I think so. Minor consent, we are working on So next steps, just kind of looking at like what the best way to move forward is. There's a couple different paths, and we will be kind of looking at kind of like how to decide the best path. I think what we are trying to figure out is whether or not we will actually need rule changes. I think actually hoping not to make rule changes, because there is a fear that actually making rule changes will open up the possibility of a large conversation around not just minor consent for behavioral health, but is the minor consent conversation for all kinds of other things like medical decisions, like gender affirming care, birth control, all kinds of things. And so, if we can avoid opening up that giant can of worms, we'd really, really like to avoid that. So, looking at maybe if we can do like a training series on what the current rules actually say, because I think people have kind of gotten away from well, the interpretation seems to be sort of a game of telephone, and what people are taking from what the rules actually say seems to be a wide range of interpretations across the state. We're also working with DOJ on our side to make sure that DOJ for child welfare, that all the caseworkers really understand what their rights and responsibilities are as caseworkers, as guardians, so that they can know what they can and cannot do. So trying to really clarify things currently to see if we need to actually make changes is where we are at the moment.
Okay, so maybe not a RAC. But
maybe not a REC. I would love for it not to be a REC.
Okay. But more technical assistance, because I know that with the TIO, you were planning to do like a recorded, more shareable version of the webinar. Has that been set yet?
No. What we're doing with TIO is actually looking at all of the different questions that came up and looking at little kind of brief trainings that will be on the TIO website. So they can, like little kind of 5-minute, hey, what about this question? Because there were a lot of like frequently asked questions that came up. So if we could just have little sort of brief answers to those questions that can live on their website. We are going to work with Mandy to get those things just so they will live in a place where people can know that there's a resource. So that's one thing that we're working on. And then if we need to do sort of a training series, if that ends up being the recommendation kind of from our leadership, then we would absolutely have those be recorded as well.
Okay, that sounds great.
Yeah. Anything about minor consent? The problematic sexual behaviors. Jennifer, you came off mute. Am I moving on too fast? Do you have a question? I will pause.
No, I was just going to share that the memo from OHA was really helpful in the updated handbook, and we really do try to share it on a quarterly basis, because if we don't, then questions start coming up at those practice level work group meetings around minor consent. So that's been very helpful, but it's also we're being mindful about making sure that information is front and center.
Awesome, thank you. That's great. That game of telephone is real. If you hear the words youth civil commitment, tamp it down wherever you can. That is not a thing. It does not exist in Oregon. It is not needed. People keep sort of, this is a thing. Like, it's not a thing. It's not needed. There are adults that make decisions for youth in that situation, so we don't need judges to be involved. So,
I'm curious if anyone has heard any questions or confusions from IDD community as it relates to minor consent. I've been in a little bit of an email exchange with a family support specialist at the Family to Family Information Center out of Ocean. And it sounds like, at least from her perspective, she's heard about some confusions from parents of kids with IDD who didn't, the memo was confusing to them about how it applies. And I'm curious if
We got
other
some
people have
questions
heard
from
that.
Ocean that came over,
Okay.
and so we'll be responding to them. They came over to Steph Murray in the adolescent school health. So she and I are responding. Some of them are more about medical issues, and so they're going to respond. The ones that are about behavioral health, I'll respond to. But there are no differences. Minors with developmental disabilities are still minors, so that we're essentially saying the rules apply the same way that they
regardless.
apply to anyone else.
Okay, great.
Anything else? So the House Bill 4086 on problematic sexual behaviors, that I was the OHA representative, so I'm speaking only from that angle. The work was resided within ODHS as the leader organization. So it was sort of a 10-month process. They convened a subgroup with a pretty broad representation of family members and young people, and then multiple different provider agencies and state agencies, and kind of with the goal of recommendations and a report at the end of it. The report is still not finalized. There is a consultant agency that was under contract from ODHS that is working on the final report. I feel like everybody was pretty much on the same page with the goal of accessing services instead of charges for young people. So that was pretty much an easy, that everyone came in with that mindset pretty automatically. So, it wasn't like a hard case to make. Where we are is as they finish their report, sort of looking at what the next steps will be. And so I will be on a group with the ODHS folks, just sort of looking at if we're going to be recommending more treatment. I think there's a pretty solid case just in the report there's a lot of disparate sort of things happening around the state, but there's not really any kind of cohesion to what's available for young people or families. There's no cohesion to trainings that are available. So sort of just saying what we need is something that is consistent, that is available across the state with sort of a plan to it. Where resources are brought together, where people know how to access resources, with trainings that are available, where we can sort of destigmatize and get people to understand what is normal sexual development, what is sort of breaking out of what you would normally develop at different age groups, get young people support at a younger age rather than looking at them as perpetrators or offenders or using this kind of negative language. I don't know. I honestly, I think no. I think
I
you
don't
should
think we're
ask
supposed
Lisa.
to.
Yeah, because I can't share the report at this point. I was given permission to share it with you. I don't know what you do with it past that. I would ask Lisa.
Well, we
from
did share it
ODHS.
with Selby.
Which Lisa
I
said
don't
we
know.
could, but I think that's sort of the end of the chain, right? Because the report is coming out publicly on September 15th and they're not done editing yet. And it gets messy if you have draft versions out and then that's not what the final version is that gets submitted to the legislature. It really will create some challenges that I know Lisa would love to avoid, and we don't need to be making things harder for our partners.
Yeah, I would agree. Yeah.
I'm
Again,
also,
I'm just
I
a
can't-
representative of the team, though. I can't make that decision for anybody.
I can't find where it is on their website, but the University of Oregon's 90 by 30 program, their child abuse prevention studies division, they have some little modules for trainings for working with folks to train people who are working with kids who may have problematic sexual behaviors on destigmatization, on appropriate resources and referrals, right? Like they're already doing some of that work that y'all are recommending be done. So like it may be something that we can take and build on and amplify. If I can find that link, I know I had it because I sent it to Lisa.
I think the idea
pop
is
it in the
like,
chat.
just to kind of pull it all together, because there's like a little bit here and a little bit there. And so it's not like, let's start from scratch. It's like, let's pull it all together and say, like, what do we have? Where are the gaps? So that's the idea. And then how do we really build on what we have and make sure that everyone has access to it?
So that they don't, as previously mentioned, have to end up in juvenile legal or child welfare in order to get the treatment and services that they need.
Exactly. The other recommendation is to stop with this below 12 and over 13 distinction. Like you were saying, Christy, that is where there's a lot of conversation around young people with IDD. Like why are we saying that like somebody who's over 13 is like automatically like an adult? Like in what world is that a thing? And heaven forbid they have any kind of developmental disability or, you know, anything impeding. We're just assuming chronological age and developmental age are just the same thing.
In lockstep for everyone, which, right. Anyone
Yep.
who's experienced trauma, those things can get off kilter, right? Like there's 1,000 reasons why those may not be the same.
So just stopping any kind of that distinction across the board in rule and law and charges and everything, and having a more developmentally appropriate approach sort of just across the board, looking at national best standards for treatment and having that be more applicable, looking at provider rates and trying to get more people trained. There's a lot of things in there.
Great. Thanks so much, Jesse. All right, we've only got like 3 minutes left. Our next meeting is, oh, Jennifer, sorry. You want to?
Sorry, I was typing some information in the chat, and so I missed, is there a work group or is there something that I can join to be a part of the work around problematic sexual behaviors? Because we did a lot within our region and I'm happy to share it.
Not at this point. The report is essentially going to point at more work, though. So the report is just a report, and it's going to say there is more work to be done. So that it is essentially a report to the legislature that's going to say, okay, here's what we recommend. And then if to do it well, it would probably involve money and resources and all the things. And so what the group was sort of saying is, if we get a position and some funds, what could we do? And if we don't get that, what could we do? And so we don't want the work to stop. And, you know, what we know is that the financial picture isn't super rosy at the moment. And so I think even without a bunch of resources, there will still be some next steps. And part of it will be pulling people who are already doing work together into sort of people who can take on some of this and do the next steps. So more to come. And if you are raising your hand, we will take you.
All right. We'll meet again in October. Is there like another barrier that people would like to do a deeper dive on? It feels like it's helpful to do that in this space. I dropped the full list of barriers that we're actively working on. I would love to hear from the folks that are still here, kind of what you want to dig into next time. Anything come to mind? We haven't talked about kind of the full world of residential treatment in a while. Jesse, I don't know if that would be of interest.
I
Anything
mean,
in the-
there are multiple barriers in there about residential. I'm happy to talk about it. Not now, but you know.
Maybe some of the work in the fee for service program. Just throwing out ideas of things we haven't really talked about that feel particularly complicated. Okay, Karsten, you're voting for residential deep dive? Okay, Chris is nodding. All right, let's plan on that for October, Jesse, if that's okay with you. Okay.
And
All
maybe
right.
some of the updates around kind of that new funding that came out, if there's anything to say about it, even if it's just here's what it is and where we're kind of looking for to put it right. Like let's look at forward looking, right? We have admired that problem.
I
from
have a
every
whole
angle.
picture. Oh, don't you worry. All the forward looking, I have plans.
Yay.
All right, that sounds great. Thank you all so much for being here. We'll get notes out and a link to the recording. And I hope you all enjoy the rest of your summer. Thanks so much.
Thanks, everyone.
Bye.